for today. We're going to go over ethics and integrated care, some common things that are seen, and some new and evolving challenges. I pulled from two major articles and then an update from the Ohio Counselor, Social Worker, and Marriage and Family Therapist Board for this didactic. So major points that I'd like to cover today. Like I said, some updates from the Ohio Counselor, Social Worker, Marriage and Family Therapist Board that I thought were relevant to share with folks. Some common ethical challenges faced when working in integrated settings, and then again, some new challenges that have presented since the pandemic began and some of the ways that those are evolving over time. First, not related to any of the other things that are in this didactic, but really important, this is a new mandated reporting requirement for Ohio counselors, social workers, and marriage and family therapists. We are now mandated reporters for animal abuse. And this is a picture of my two lovely dogs, because who could ever think of not reporting animal abuse when you see such lovely creatures? Granted, they are a total pain, but it is nice to know that finally we are in a position where where licensees of the board, if they need to make a report, they are immune from civil or criminal liability for making such a report. And it's very similar to reporting elder abuse or neglect, child abuse or neglect. We're now mandated to report animal abuse or neglect. So in making a report, licensees should be prepared to include a description of the animal and the animal's name if it's known, the address and phone number of the owner or whoever's supposed to be taking care of the animal if it's known, the nature and extent of suspected abuse, and any other information that might be useful in identifying who the potential abuser is. I'm really excited about this. Like I said, it doesn't actually relate to anything else. I just thought it was a really important update. Themes that you are seeing across integrated healthcare settings. And I pulled some of this, or most of it, from an article by Susie Wang, but it does parallel actually kind of the article that we talked about in the Journal Club last week and some other things that have come out. Major common themes that are seen as ethical dilemmas in integrated care tend to be around informed consent and how that intersects with patient autonomy and with privacy and confidentiality. And the author points out that an ethical dilemma occurs when you counter multiple choices and there might not be a clear right answer. The choices potentially have all undesirable or less than desirable outcomes, and the choices are in conflict with ethical values. So any interprofessional team that we work on in integrated healthcare settings, every profession on the team comes from a different educational and training background. We're all guided by our own codes of ethics. And while there's a lot of similarities, there are some differences. And when you compare specialty mental health settings like a community mental health center to integrated care within a primary care setting, the expectation in a primary care setting is going to be to work at a faster pace and have different privacy expectations than a counselor, social worker, or psychologist might have if they were working in specialty mental health. In integrated health settings, counselors and social workers and psychologists often serve as a middle person and can be caught between patients and other providers, sometimes other organizations, occasionally policies in the community. And families might even come into struggle with treatment decisions. And so these mental health providers in the primary care settings might have to not only mediate, but provide support and try to be kind of a middle person and create some balance. So specific to informed consent and patient autonomy. So there might be situations where patients disagree with the care plan or decline some of the suggestions made by the medical team. And often that mental health professional might end up in a position of having to understand what the patient's concerns are, of what the patient is reluctant about with the plan on, and figure out how to become then a mediator between the primary care team as a whole and the patient. This is often just because mental health providers are given more time with patients than primary care doctors and nurse practitioners often are. Mental health professionals on an integrated team can try to safeguard a patient's self-determination, which we're ethically obligated to try to safeguard a patient's self-determination and autonomy. But they can do this by reviewing treatment plans with patients to ensure that they're in agreement and that they actually understand what the treatment plan is and understand their own right to make their own decisions. In the study by Wang, participants in the study noted that They try to understand why the patients disagree, and then try to bring the patient's positions and reasoning forward as an advocate to the team. But often this makes people feel uncomfortable if they feel like they're going against or challenging their team members, because they want to be all on the same team, but they're also trying to advocate for the patient at the same time. So priority areas and are also going to differ depending on what your specialty is, your background, training. We might come into this with different value systems and different priority areas. And specific to mental health professionals, there's a large push in advocacy. So being able to be that advocate while also not disrupting the team dynamic is important, but can be a challenge. My PowerPoint is jumping all over the place today. Another area is around privacy and confidentiality, and whether information is being shared internally with an internal team that is within the same facility, or externally for that coordinated collaborative care outside of the physical bounds of the building. That might make this area of privacy and confidentiality a little bit more or less gray. We see challenges when we've talked about HIPAA and what is and is not allowable under HIPAA, lots of times in the past. And we know that people, depending on agencies and sometimes depending on company policies, misinterpret or utilize HIPAA in a way that is not completely in alignment with the law. It sometimes feels like an excuse just not to fill information or to share information, is just leaning on HIPAA. And I think sometimes that's based on a misunderstanding. And again, company policy can be very different than what the law is. But this can be a very challenging piece, because on one hand, with the team, you want to share all of the information. It allows us to share the information, but we also want to respect the patient's right to privacy. So how much information do you share with the whole team? And what is the need to know behavior? And when there is risky behavior and things that the whole team needs to know, and maybe the patient doesn't want the whole team to know it, how do you then work with the patient to make sure that they understand why this information is important for everyone to have on the team? And so building that trust with the patient and helping them understand the benefit of the whole team having the information, or at least the minimal necessary information to understand how to treat this person from a holistic standpoint. There's been a long-term balance of how much mental health information gets shared with all team members within integrated care, because patients might have a limited understanding of how the information is going to be used. And there's plenty of cases in history of it being used inappropriately or in a way that made the patient feel uncomfortable, as well as stigma around mental health issues and mental health diagnoses. And when studies have looked at what patient preferences are, patients do seem to have a preference on being able to limit who has access to what information and being the ones to maintain control over that. So it does create a really awkward spot for those mental health team members on, well, I know that I need to share all of this, but I also need to balance the patient's right to privacy on some topics. All of this has been further challenged by the pandemic, and new ethical issues have come out of the pandemic. The Cooper and Zerston study actually looked at how COVID-19 impacted the behavioral health services within a FQHC that is also a patient-centered medical home, where they were providing primary care behavioral health. So this is then, again, them doing mental health within the primary care setting. And some of the new ethical issues were whether or not to do in-person visits based on personal safety and patient safety and the risk of transmission of COVID-19. Obviously, when things started to open back up and there's this, well, we can do some telehealth or some in-person health, both patients and providers were nervous about how do we do the in-person stuff, and is it ethical to do the in-person stuff and risk transmission, or am I possibly missing signs, missing nonverbals? Am I giving the best care to the patient if I'm only on video? So there's a lot of concerns about how do we best meet the patient's needs and preferences, and also keep everybody safe. Also, a big discomfort with digital devices on both the ends of the provider and patient end. Providers might not have had to do telehealth before. Everybody had to learn very fast, which obviously presented some major concerns. Other issues around telehealth is now if people are working from their home, are they doing telehealth or video visits, counseling visits, and mental health visits with patients from their home? Are they accessing the medical record offsite? Anything, as soon as you start doing this, the potential for reduction in confidentiality and privacy is there. And also, we can't know who's in the room with the patient while we're doing that visit. We hope that nobody's in the room with us as the mental health provider doing that visit, but certainly there could be somebody in another room that could hear, and that really is it is a HIPAA violation. So all of this brought things into question, like how do we do this and still maintain the patient's privacy and confidentiality? How do we do the best job that we can? Added on top of all of that is when you have a lack of technological resources for the actual patients, whether that's access to internet at all, access to decent internet, a patient's digital literacy. Many patients share phones, so they might not always have that phone. And when they do share phones, are they actually able to be in a private space when they're talking? Even more so when you think about issues around domestic violence, if a person is needing to talk to a therapist or their primary care physician or whoever about their providers and their team about issues of potential violence in the house, but now they have to have that conversation from within the house, obviously they're not going to feel very comfortable in doing so and might be putting themselves at a higher risk. There's lots of issues that have come up during the pandemic that we've had to sort out, I guess, one at a time. And as we transition out of the pandemic, we're adapting once again. So now that the state of emergency has been lifted and the COVID restrictions have been lifted, those standards and the flexibility that had been created under the laws for teletherapy and video visits are now shifting back to what they were before. So initial face-to-face meetings now have to be face-to-face. And where I put an asterisk by the video audio electronically because that's written in a way that I feel like I'm still unsure what they're saying. Are they saying that the face-to-face meeting has to be in person, like actually in the same room, or are they saying that the first meeting can actually be over video? Because those would be two very different things and considerations that need to be taken, that we need to actually know what the specifics are. And I was not very clear from the counselor, social worker, marriage and family therapist update which one they were saying. It also transitions us back to, instead of verbal informed consent for treatment, now it's all in writing. So you have to get that hard signature. And issues around using encryption methods for HIPAA that are compliant for teletherapy and video therapy. And they do put an exception here for any kind of reminders or scheduling contacts, which clients can opt out or waive the encryption for the text reminders that they have an appointment coming up. This also extends to providing training supervision. The board does require face-to-face. Now they say that face-to-face can be on video, but during the pandemic, a lot of this stuff was loosened. And now that those restrictions have been, the restrictions on our social distancing and masks have been lifted, now we're transitioning back to some of the old rules. And yet there are some things that we still need to keep in play, because teletherapy also, we found to be very beneficial for a lot of patients. It's not for everybody. It's not going to work for everybody, but it can work very well for others. So summary considerations, ethical issues are going to arise in integrated care. Many of them are going to be around informed consent, confidentiality, and patient autonomy, and how we balance all of that while also sharing information collectively as a team. New challenges came up during COVID, and transitioning back to pre-pandemic rules is going to create even new challenges. We have to remember to keep flexible and to not get very rigid around these things. And hopefully our legislatures will also remember that we cannot be rigid. We're still in process. You can't just pull a Band-Aid off and things go back to the way they used to be, and probably shouldn't. Seek consultation when you're unsure of what to do. It's not a plug for ECHO, but could be. And communication. Take the time to work through ethical challenges as a team. It can not only help the team with communication, but it can build relationships, helps to avoid problems, and also helps keep all of us in the world of self-care and being, just good humans to one another, which is hopefully all of our goal. Those are my references, and I will stop